Okay, imagine this for a second. There's this potential hidden weakness deep inside your body.
Something you'd likely have no idea was even there.
Exactly. But if it were to, burst, it could be catastrophically dangerous.
Yeah, we usually hear about aneurysms in the big one, the aorta.
Right. The
Yeah.
aorta gets all the attention. But today we're diving into a lesser known area, visceral artery aneurysms.
And surprisingly, these bulges in the arteries feeding your abdominal organs, think spleen, liver, intestines, they can be just as deadly if they rupture.
So what's really interesting here, while most abdominal aneurysms, maybe 95%, are aortic or renal, happening in the arteries to the kidneys.
There's this whole other story with the arteries supplying the rest of the abdominal organs. These are the visceral arteries.
And that's our focus today, these dilations, these aneurysms in the vessels going to the spleen, liver, gut, and so on.
Right. And just to be super clear, even though they're in the abdomen, we're specifically excluding the aortic and renal artery ones for this deep dive. They're
Yep.
kind of their own separate topic.
Okay. So our goal today is really to shed some light on these rarer but pretty significant lesions.
Yeah, we want to give you a clear, sort of concise understanding. Think of it as valuable background knowledge on how your body works, maybe some hidden vulnerabilities.
And we've really dug into some authoritative sources here, specifically chapters from the latest Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. So solid information.
Definitely. And we're hoping to uncover some maybe surprising facts and look at how the ways we manage these conditions have really changed over time.
So maybe let's start with a bit of history. How did we even figure these things out?
Well, historically, it was often not great news.
Mhm.
Understanding really started reactively. For a long time, these were often only found after they'd ruptured.
So post-mortem, basically.
Often, yes, during autopsy. It wasn't until 1903 that the first successful surgical repair happened. Someone ligated or tied off a hepatic artery aneurysm, the one going to the liver.
Wow, 1903.
Yeah. And then you jump to the 1950s for the first successful repair of an aneurysm in the superior mesenteric artery. That's a major one for the intestines.
It really puts into perspective how far things have come with modern medicine and imaging.
Absolutely. Technology has revolutionized how we find and manage them.
Okay, so let's get a handle on how common these actually are. What are the numbers like?
Generally speaking, in the adult population, estimates are somewhere, between 0.1% and maybe 2%.
So relatively rare overall.
Relatively rare, yes. But here's a kicker. Autopsy studies in older individuals, they've found these aneurysms in up to 10% of cases.
10%,
Yeah,
that's a lot higher. Suggests maybe they become more common as we age.
it certainly suggests that, yeah, they might be accumulating over time.
And where do they tend to show up most often? Is there a pattern?
Oh, definitely. The splenic artery, the one going to the spleen, is the runaway leader. About 60% of all visceral artery aneurysms are found there.
60%. Okay.
Then comes the hepatic artery, supplying the liver. That's around 20%.
Still pretty significant.
After that, it drops off. Superior mesenteric artery, feeding a lot of the bowel, it's about 6%. Celiac artery, gastric artery, both around 4%.
Celiac supplies the stomach, liver, spleen, gastric mainly the stomach.
Exactly. Then you've got a group of smaller intestinal arteries, jejunal, ileal, colic, lumped together at another 4%. Pancreatico-duodenal is about 2%, gastroduodenal 1.5%.
And bottom of the list.
Inferior mesenteric artery, feeding the lower colon, less than 1%. So it really paints a picture of which pathways are most susceptible.
That's a super helpful breakdown. Now you hear terms like true aneurysm and pseudoaneurysm. What's the actual difference? It sounds important.
It's absolutely crucial. So think of a true aneurysm like this. The actual wall of the artery itself becomes weak, all the layers, and it balloons outwards.
Like stretching a weak spot in a balloon.
Precisely. And the causes, things like atherosclerosis, plaque buildup, are common. Also, a natural weakening of the artery's middle layer, what we call medial degeneration, certain diseases affecting connective tissue, like collagen vascular diseases, or a condition called fibromuscular dysplasia.
Okay.
Interestingly, for some specific locations like the splenic artery, things like having multiple pregnancies or high pressure in the liver's veins, portal hypertension can contribute. Even blockages further up, like in the celiac artery, can sometimes lead to aneurysms downstream in the pancreatic duodenal arteries.
So the wall itself is compromised. What about these pseudo ones, false aneurysms?
Right. Pseudoaneurysms are a whole different ballgame. Think of it more like a leak or a rupture that's been contained
Contained how?
by the surrounding tissues. So blood escapes the vessel, but it doesn't burst freely. It forms a pocket held in by the nearby structures. It's not a true expansion of all the layers of the artery wall.
And what causes those? Not wear and tear, then?
Usually not. It's typically caused by some kind of direct injury or disruption to the artery. Infection is a big one. Inflammation of the vessel wall, vasculitis. Sometimes it happens, unfortunately, as a complication of surgery or another medical procedure. We call that iatrogenic or straightforward trauma.
Okay.
A really key thing about pseudoaneurysms is that they tend to grow faster, relatively speaking, after that initial injury.
Which means they're maybe more urgent?
Generally, yes.
Yeah.
That rapid growth potential is why doctors are often keen to treat them pretty quickly, often regardless of their size.
So it's not just the usual suspects like atherosclerosis. Are there other, maybe more surprising links?
Absolutely. There are some rarer conditions associated with these, things like von Recklinghausen disease, Ehlers-Danlos syndrome, which affects connective tissue, periarteritis nodosa, Behçet disease.
Okay, those are pretty specific syndromes.
They are, and there are also links with more widespread inflammation of arteries, like systemic arteritis, infections of the heart valves, endocarditis, where little infected clots can break off and travel.
Septic emboli.
Exactly. Other connective tissue disorders, too. And quite surprisingly, there have even been reports linking some cases, particularly multiple aneurysms, to excessive use of acetaminophen.
Acetaminophen, like Tylenol. Wow, that is definitely unexpected.
It really is. It just highlights how complex the body is and how many factors can potentially play a role.
That's fascinating.
And another really important point, thinking about screening and overall patient assessment. These visceral artery aneurysms often don't happen in isolation.
Meaning if you find one, you should look elsewhere.
Precisely. In nearly a third of patients with a visceral artery aneurysm, you'll find other aneurysms lurking somewhere else.
Like where?
Common spots are the aorta, the renal arteries, the iliac arteries down the pelvis, arteries in the legs, even cerebral aneurysms in the brain.
Almost 1 in 3. That really drives home the need for a thorough vascular workup if one of these is found.
It absolutely does. It suggests a systemic predisposition in many cases.
Okay, so we know what they are, where they occur, roughly how often, and some causes. Let's talk treatment. What are the general principles guiding doctors here?
Well, the landscape has really shifted, particularly with the rise of endovascular techniques. Procedures done from inside the blood vessels using wires and catheters.
Minimally invasive stuff.
Exactly. So now, the toolkit includes traditional open surgery, sometimes less invasive laparoscopic surgery, these endovascular options, or even a combination. But there's no single one-size-fits-all rule.
So how do you decide?
It really boils down to two main things: the patient and the aneurysm.
Yeah.
For the patient, you're looking at their age, their overall health, any other serious medical conditions, comorbidities.
Okay.
And for the aneurysm, you need to know its size, crucially, where exactly it's located, and whether there's good collateral circulation, meaning are there other blood vessels that can take over if the main one is blocked or tied off.
So it's a very personalized decision. What about the difference between fixing one electively, planned versus an emergency?
Right. So in an elective setting, the aneurysm hasn't ruptured. We have time. Time for a really thorough evaluation.
Imaging, presumably.
Lots of imaging. Usually ultrasound, CT scans are very common, sometimes MRI or angiography, which is like a live X-ray map of the blood vessels using contrast dye. This gives us the detailed anatomy we need to plan.
What else goes into that planning?
Doctors will also dig into the patient's history, any past trauma, pancreatitis, infections, anything that might point to a cause, especially for pseudoaneurysms. And an interesting point, if we're planning to treat a splenic artery aneurysm, especially with embolization or surgery that might risk the spleen, we might actually recommend certain vaccinations beforehand against encapsulated bacteria, because there's a chance the spleen might need to be removed or its function impaired, and that increases infection risk later.
That makes sense. Proactive measure.
Exactly. And in these planned elective cases, endovascular options are often the first choice now, especially if the patient is maybe older or has other health issues, making open surgery riskier.
Okay. But what if the worst happens? What if one ruptures? That sounds like a scramble.
It's a critical emergency. Immediate attention needed. Often the patient comes in unstable, in shock. Sometimes the initial thought might even be a ruptured aortic aneurysm, just because that's more common.
And the real cause is found during surgery.
It can be, yes. The priority is stopping the bleeding fast. Usually that means emergency surgery to ligate the vessel, tie it off. Sometimes repair or reconstruction might be possible, but often ligation is the quickest way.
What about the organ it supplies? if you tie off the splenic artery?
Good question. If a splenic artery aneurysm ruptures, the spleen itself is often removed as part of controlling the bleed. For some other visceral arteries like the proximal hepatic artery or the pancreaticoduodenal and gastric arteries, there's often enough backup blood supply, enough collateral flow that simple ligation is okay.
But not always.
Not always. The mesenteric arteries, the superior and inferior ones supplying the intestines, that's trickier. If you just ligate an aneurysm there, especially the SMA, there's a significant risk of bowel ischemia, where parts of the intestine don't get enough blood.
Which could mean needing to remove parts of the bowel.
Potentially, yes. So for ruptured SMA or celiac artery aneurysms, surgeons are more likely to try and reconstruct the artery if possible to maintain that vital blood flow.
And can endovascular techniques help in emergencies?
Increasingly, yes. In select cases, if the patient is stable enough and the anatomy is suitable, endovascular approaches like covered stents or embolization are becoming feasible even for ruptured visceral aneurysms. It can be faster and less invasive than open surgery in the right situation.
It sounds like sometimes, though, doing nothing, immediately just watching might be the right call. When is observation an option?
You're absolutely right. Doing too much can also have risks. Several studies have shown that for certain patients, particularly with splenic artery aneurysms, careful observation is a safe initial approach.
What qualifies for observation?
Generally, the guidelines lean towards observing asymptomatic splenic artery aneurysms, ones not causing problems if they're less than 3 centimeters in diameter.
About an inch or so.
Roughly, yes. And crucially, they need to show little or no growth on follow-up imaging, maybe less than half a centimeter per year.
But there must be exceptions.
Big exceptions. One is pregnancy. Any splenic artery aneurysm found in a woman who is pregnant or of childbearing age should generally be treated, regardless of size.
Why the difference?
The risk of rupture skyrockets during pregnancy, particularly in the 3rd trimester, and the consequences are devastating for both mother and baby.
Okay, that's a critical point. Any other automatic treat categories?
Yes, all pseudoaneurysms, remember those contained leaks, treat them. Regardless of size or location, their rupture risk is just too high.
Because they grow fast.
Exactly. And finally, the evidence suggests that aneurysms in certain locations, specifically the superior mesenteric artery, SMA, the gastroduodenal artery, GDA, and the pancreaticoduodenal arteries, PDA, just have a naturally higher tendency to rupture.
So even if they're small?
Even if they're small, intervention is often recommended for those specific types. Observation might be considered only in very high-risk patients who couldn't tolerate any procedure.
Okay, so if treatment is needed, let's get into the techniques. You mentioned open surgery and endovascular. Tell us more about the surgical side first.
Sure. Open surgical repair is the traditional approach, obviously been around the longest, and has a very solid track record for safety and long-term effectiveness when done electively.
What does it actually involve? Cutting out the aneurysm.
Sometimes. Aneurysmectomy, removing it, is one option, often followed by reconstruction, maybe using a piece of vein as a bypass graft. But often, especially if there's good collateral flow, like we talked about with the spleen, simple ligation is enough.
Just tying it off above and below the bulge.
Exactly. Proximal and distal ligation. That excludes the aneurysm from circulation. If there's any concern about infection, surgeons usually prefer using the patient's own vein for any reconstruction rather than a synthetic graft.
And in an emergency rupture.
Ligation is often the go-to. It's usually the quickest, most direct way to stop the hemorrhage when the patient is unstable.
Makes sense. Now, these endovascular options seem to be really changing the game. What are the pros and cons there?
The advantages are pretty compelling. Generally, shorter hospital stays often can be done under local anesthesia or sedation rather than general, potentially lower upfront costs, and definitely a faster recovery time for the patient.
Sounds good, especially for patients who might not handle big surgery well.
Precisely. It's a great option for patients with significant comorbidities. But it's not without potential downsides.
Such as?
Well, there are risks related to getting access into the artery in the first place, bleeding or damage at the puncture site, usually in the groin. There's the contrast dye used for imaging, which can potentially affect kidney function.
Right, contrast toxicity.
Yeah. And then there's the risk of accidentally blocking off blood flow to other nearby organs if a coil or stent migrates non-target embolization. And compared to open surgery, sometimes the initial endovascular fix might not be completely successful, or the aneurysm might recur later.
So more need for follow-up imaging.
Definitely. Long-term surveillance is usually required after endovascular repair, So several different techniques fall under this endovascular umbrella, and often they're combined.
Okay. Like what specifically?
Probably the most common is embolization. This involves packing the aneurysm sac itself, or the artery leading to it, with materials to make it clot off.
What kind of materials?
Tiny platinum coils are very common, sometimes a special medical-grade glue like cyanoacrylate, or even tiny particles or a substance called gel foam, which is like a spongy gelatin that promotes clotting.
So you're basically blocking it up from the inside.
Essentially, yes.
Yeah.
Another major technique uses stents. Covered stents are like small, fabric-lined metal mesh tubes. You place them across the neck of the aneurysm, inside the main artery.
So blood flows through the stent, bypassing the aneurysm sac.
Exactly. It excludes the sac from circulation while keeping the main vessel open. The challenge there can be accurately placing them, especially in smaller, twisty arteries, and there's a risk of covering over the opening of important side branches.
I see. Any other stent types?
Yes. More recently, flow-diverting stents have become available. These are a bit different. They have a denser mesh structure.
How do they work?
They're placed in the parent artery, across the aneurysm neck, similar to a covered stent. But instead of completely blocking flow into the sac, they significantly slow it down and change the flow dynamics.
And the idea is?
The idea is that the slowed, stagnant flow within the aneurysm sac encourages it to thrombose clot off naturally over time, while still allowing blood to flow normally to the main artery, and importantly into any small side branches covered by the stent.
Ah, so potentially less risk of blocking those side branches.
That's the hope. These were originally developed for treating brain aneurysms, intracranial ones, but early results for using them in visceral arteries look quite encouraging too.
Fascinating technology. It really sounds like a sophisticated toolkit. Okay, let's use that framework now and dive into the specifics of some of these aneurysms, starting with the most common one you mentioned, splenic artery aneurysms, SAAs.
Right, it's SAAs. The most frequent, about 60% of the total. And here's an interesting demographic point. They affect women much more often than men. The ratio is about 4-to-1.
4 times more common in women. Any idea why?
The exact reasons aren't fully nailed down, but there's the strong association with multiparity having multiple pregnancies. Hormonal changes in blood flow during pregnancy likely play a role. Also, they tend to be found in slightly younger people compared to other visceral aneurysms, though they do still increase with age overall.
And size-wise?
Most are found when they're around 2 centimeters in diameter, but the ones that actually rupture tend to be a bit larger, closer to 3 centimeters on average. Location-wise, they're usually in the middle or distal part of the splenic artery, further away from the aorta.
Okay. And causes, besides the link with pregnancy?
The usual suspects for true aneurysms are there. Atherosclerosis, a condition called arterial fibrodysplasia, sometimes arteritis or inflammation. But those links to female gender, multiparity, and also portal hypertension, a high pressure in the liver circulation, are really key distinguishing features for SAAs.
Portal hypertension, like from liver disease?
Exactly, or sometimes after liver transplant. That increased pressure seems to predispose to SAAs. But despite the pregnancy link, we don't generally recommend routine screening for SAAs just because someone is pregnant or planning to be.
Okay. What about splenic artery pseudoaneurysms? Same causes?
No, those are usually different, often related to injury, blunt abdominal trauma, for instance, or infections, and quite commonly pancreatitis, inflammation of the pancreas.
Pancreatitis can cause them.
The inflammation and enzymes from the pancreas can erode into the nearby splenic artery. And these pancreatitis-related pseudoaneurysms can sometimes lead to a really dangerous complication called hemosuccus pancreaticus.
Hemosuccus pancreaticus, what's that?
That's where the pseudoaneurysm actually ruptures or leaks into the pancreatic duct system. So the patient ends up bleeding into their gastrointestinal tract through the pancreatic duct. It can be difficult to diagnose and very serious.
Wow. Okay, so for SIs in general, what's the bottom line on risk and treatment?
Well, before good imaging, many were found only after rupture. Now, most are found incidentally, by chance, on scans done for other reasons. For non-pregnant people, the actual risk of a true SAA rupturing is pretty low, generally quoted as less than 2%.
But pregnancy changes everything.
Dramatically.
Yeah.
Rupture risk goes way up. Maternal mortality, if it ruptures during pregnancy, is around 75%, and fetal mortality is even higher, about 95%. It usually happens in the 3rd trimester.
Those are terrifying numbers.
Yeah, they really are. Portal hypertension also increases the rupture risk. And pseudoaneurysms, as we said, have a much higher rupture risk than true aneurysms.
So the treatment guidelines reflect that.
Yes. Basically, you treat any SIA that is ruptured is causing symptoms, or is the pseudoaneurysm.
Mm.
And you treat all SAAs found in pregnant women or women of childbearing age, pretty much regardless of size.
And for the others, asymptomatic true aneurysms in men or non-childbearing women.
The trigger for intervention there is usually size greater than 3 centimeters in diameter, or significant growth more than half a centimeter in a year on follow-up scans.
And the treatment options, surgery, endovascular.
Both are effective. Surgery might involve removing the aneurysm and usually the spleen along with it, a
Yeah.
splenectomy, or sometimes just ligating the artery. Endovascular options are very common now, using coils or glue to embolize the aneurysm, or placing a stent graft.
Any specific issues after endovascular treatment for SAAs?
One thing to be aware of is post-embolization syndrome, or PEs. After you block off flow, parts of the spleen might infarct or die off. This can cause symptoms like fever, abdominal pain, sometimes a pleural effusion. It's usually self-limiting but needs to be recognized.
Okay, good to know. Let's move downstream to the liver. Hepatic artery aneurysms, HAAs. Second most common, you said.
That's right, HAAs make up about 20%. And interestingly, unlike splenic, these tend to be more common in men. Ratio is about 3 to 2 male to female.
Any reason for that difference?
Not entirely clear, but it might relate to underlying causes. And it seems like we're seeing more of them reported, possibly because we're doing more procedures involving the liver, and bile ducts instrumentation can sometimes lead to injury and pseudoaneurysm formation.
Where do they usually occur?
About 3/4 to 80% are extrahepatic, meaning outside the liver tissue itself. The common hepatic artery, the main trunk before it branches, is the most frequent spot.
And rupture risks.
Reported rates vary quite a bit in the literature, anywhere from 20% up to maybe 80% in some older series. But unlike SAAs, there's no known link between HAAs and pregnancy. The average age when they're found is around 60, unless it's trauma-related.
What are the main causes for HAAs?
For true HAAs, atherosclerosis is number one. High blood pressure is often present too. Arterial dysplasia, trauma, biliary tract diseases can also contribute.
But you mentioned procedures causing them.
Yes, and that's become a really significant factor with the rise in things like liver biopsies, biliary drainage procedures, even laparoscopic cholecystectomy. Iatrogenic pseudoaneurysms caused by injury during these procedures are increasingly common. They now make up a large chunk of recorded HAAs.
So fewer infection-related ones now.
Fewer mycotic ones, yes. They used to be more common, linked to things like endocarditis, but widespread antibiotic use has reduced that. And just like other visceral aneurysms, about a third of HAA patients have other visceral aneurysms, and nearly 40% have aneurysms elsewhere in the body, like the aorta.
How do these tend to present symptoms?
Again, many are found incidentally on imaging. If they cause symptoms, it might be abdominal discomfort or back pain, perhaps suggesting rapid expansion.
And the rupture risk for these?
For larger true HAAs, the rupture risk is estimated around 25%. Pseudoaneurysms generally have a higher risk. Rupture can happen into the abdominal cavity or, interestingly, into the bile ducts.
Leading into the bile ducts.
Yes, causing something called hemophilia. There's a classic triad of symptoms sometimes seen with this called Quincke's triad. The hemophilia itself, jaundice, yellowing skinnies, and pain in the upper right abdomen. Rupture can also occur to the stomach, causing GI bleeding, but that's less common.
And mortality if they rupture.
It's high. Reported rates are anywhere from 20 to 70%. Pseudoaneurysms are often more symptomatic to begin with and carry that higher rupture risk.
So who gets treatment for HAAs?
The general guidelines are treat all pseudoaneurysms. Treat any symptomatic aneurysm. For asymptomatic true aneurysms, treat if they're larger than 2 centimeters or if they're growing more than half a centimeter per year, assuming the patient is a reasonable candidate for intervention.
Any other groups?
Yes, patients with multiple HAAs or those associated with inflammatory conditions like vasculitis should probably be treated regardless of size.
And the treatment methods, similar to splenic.
Similar options exist. Open surgery could involve repairing the wall directly, aneurysmorrhaphy, ligation with or without bypass grafting to maintain liver blood flow, or resection. Endovascularly, coil embolization is very commonly used and effective, especially for pseudoaneurysms and those within the liver branches.
Intrahepatic ones must be tricky.
They can be. You have to be very careful about preserving blood flow to the liver segments when you embolize. Sometimes sacrificing a small branch is necessary and tolerated, but major branches are critical. Liver function needs careful consideration.
Makes sense. Okay, let's tackle the superior mesenteric artery aneurysms, SMAs. You mentioned these have some serious risks.
They do. SMAs are less common, maybe 3.5 to 8% of the total. But what makes them stand out is that historically and even often today, the most frequent cause is infection.
Infection, mycotic aneurysms.
Exactly. Mycotic aneurysms might account for up to 60% of SMAs. These often occur in younger patients, maybe under 50, and there's often a history of bacterial endocarditis or IV drug use seeding the infection.
What about non-infectious causes?
Atherosclerosis and connective tissue diseases can cause true SMAs. Trauma can cause pseudoaneurysms here too. Location-wise, they almost always occur very proximally in the first 5 centimeters of the SMA, near where it originates from the aorta.
And the big concern is the bowel supply.
Precisely. The SMA supplies a huge territory, most of the small intestine and the first part of the large intestine. So rupture is catastrophic, and even complications from treatment, like accidentally blocking branches during endovascular repair, can lead to widespread bowel ischemia.
How do these present? Are they usually silent until rupture?
Interestingly, unlike some others, non-ruptured SMAs are actually more likely to be symptomatic. Patients might have vague, crampy abdominal pain, maybe pain after eating, intestinal angina, or unexplained weight loss.
And rupture rates?
High. Estimates range from 38% up to 50%, and mortality after rupture is also grim, maybe 30 to 90%.
Wow. So treatment approach must be aggressive.
Very much so. Because of that high rupture risk, societal guidelines generally recommend repairing all SMAs as soon as they're diagnosed, regardless of size.
All of them. No observation.
Well, maybe the only exception considered is for a very small, true SMA aneurysm in a patient who is an extremely poor candidate for any kind of intervention. But generally, the rule is treat. And definitely all pseudoaneurysms and mycotic aneurysms need repair.
Surgical or endovascular.
Both are options. Surgery might involve aneurysmectomy, maybe with reconstruction using a graft, or sometimes ligation if collateral flow is excellent, which is rare here. Endovascular treatments like coil embolization or covered stent grafts are used, especially for high-risk patients.
But you mentioned the risk to bowel branches.
Yes, that's the critical challenge with endovascular SMAA repair. The SMA has major branches coming off very close to where these aneurysms usually occur, like the jejunal arteries, the iliac artery. You have to be incredibly careful not to inadvertently cover or embolize those during the procedure. Intestinal ischemia is a real risk.
Definitely sounds like a high-stakes area. Okay, what about celiac artery aneurysms, CAAs?
Celiac aneurysms are also relatively rare, around 4%, often found alongside other visceral or aortic aneurysms. Atherosclerosis is a major cause now, though infection used to be implicated more often, maybe in 20% of cases historically.
Who gets these, typically?
Tend to be discovered in men, often in their 50s or 60s. Way back, things like syphilis were blamed, and diagnosis was often post-mortem after rupture. Now, atherosclerosis and medial degeneration are more common culprits.
Any other associations?
There's a link with something called median arcuate ligament syndrome, where a ligament compresses the celiac artery. That chronic compression and turbulent flow might contribute to aneurysm formation in some people.
And clinically, rupture risk.
CAAs are notorious for high mortality if they rupture. Historically, it was near 100%. More recently, it's maybe closer to 50%, but still very high. And unfortunately, we don't have great predictors for which CAAs are going to rupture.
Symptoms?
Can be vague abdominal pain, maybe post-meal pain suggesting intestinal angina if flow is compromised. Rupture itself causes sudden severe abdominal pain and shock.
Is there anything unique about their rupture pattern?
Yes, they can exhibit something called double rupture, which is also seen sometimes with splenic aneurysms. This happens in about a quarter of ruptured CAAs. The initial rupture is contained maybe into the lesser sac of the abdomen, and then there's a secondary, free rupture into the main peritoneal cavity.
So who gets treatment?
Guidelines recommend treating all symptomatic CAAs, all pseudoaneurysms, and true CAAs larger than 2 centimeters. Observation might be okay for smaller, stable ones, especially in high-risk patients.
And techniques.
Surgery can involve ligation, aneurysmectomy, or aneurysmorrhaphy. Endovascular options, embolization, stent grafting are increasingly used and generally preferred if technically possible, due to lower morbidity compared to open surgery for this location.
Okay, we've hit the main ones. Let's quickly cover the really rare types now. Gastric and gastroepiploic.
Right, GAAs and GEAAs. Very rare, less than 4% combined. The alarming thing here is that they have an incredibly high tendency to present with rupture over 90% of reported cases.
90% rupture on presentation.
Yes, and mortality is high, around 70%.
Yeah.
So the takeaway is simple.
Yeah.
If you find one of these before it ruptures, It absolutely needs to be treated.
How?
Surgically, by removing or excluding the aneurysm, or endovascularly, usually with embolization, making sure to block the artery both proximal and distal to the aneurysm to prevent back bleeding into it.
Got it. What about those pancreatic duodenal and gastroduodenal artery aneurysms, PDAAs and GDAAs? Delicate area, you said.
Extremely rare, PDAAs maybe 2%, GDAs 1.5%.
Yeah.
Often there are pseudoaneurysms linked to pancreatitis, or sometimes related to celiac artery occlusion, where flow increases through these collateral pathways. Trauma is another cause.
Symptoms, risks.
Symptoms are often just vague upper abdominal or epigastric pain, but they have a high rupture rate and significant mortality even if treated. Because of this, like SMAAs, treatment is generally favored regardless of size.
Options.
Surgical ligation or resection if possible. Endovascular embolization is common, sometimes using thrombin injection directly into the sac to induce clotting, especially for pseudoaneurysms related to pancreatitis.
And finally, the really obscure ones. Inferior mesenteric, jejunal, ileal, colic artery aneurysms.
Extremely rare. Causes aren't well defined. Maybe inflammation or infection plays a role. They tend to be small. They can rupture, causing GI bleeding with maybe a 20% mortality rate.
Treatment guidelines.
Elective treatment is usually advised for jejunal or ileal aneurysms over 2 centimeters, and probably for all colic artery aneurysms just because they're so rare and unpredictable. Surgery involves aneurysmectomy or ligation. Endovascular cases are very limited due to rarity and size.
One last category, venous aneurysms.
Visceral venous aneurysms are exceptionally rare. Usually occur in the portal vein system, the veins draining the bowel and spleen towards the liver. Complications like thrombosis or rupture are uncommon.
So mostly observation.
Mostly observation. Surgical repair is reserved for symptomatic cases or complications. The role for endovascular treatment here is really undefined.
Wow. Okay, that was an incredibly thorough journey through a complex and somewhat hidden corner of vascular medicine.
It really covers a wide spectrum, doesn't it?
It does. So just to quickly recap the big takeaways, visceral artery aneurysms, though much rarer than aortic ones, are definitely significant and potentially life-threatening.
Absolutely. And distinguishing between true aneurysms and pseudoaneurysms is key, as their causes, behavior, and often management strategies differ.
We've seen this real evolution in treatment, haven't we? From primarily open surgery to this rapidly expanding field of endovascular therapies.
Right, offering less invasive options, which is huge for many patients. But open surgery still has a crucial role, especially in emergencies or complex cases.
And the decision-making hinges on what?
For true aneurysms, it's largely about size thresholds, growth rate, location, and crucially, the patient's overall health and surgical risk. But for pseudoaneurysms and certain high-risk locations like the SMA or PDAA, the approach tends to be much more aggressive treat than when found.
Yeah. And if we bring this back to you, the listener, it really does make you think, doesn't it, about these potential silent threats, these vulnerabilities that could exist within our own complex circulatory systems.
It really does. And it also highlights the incredible advancements in medical imaging that allow us to even find these things incidentally now, and these sophisticated, often minimally invasive tools we have to manage them.
Which leads us to our final thought for you to mull over. Knowing that these silent dilations can exist in this intricate network, what other hidden conditions might be present within us? And maybe how will future medical innovations continue to shed light on and help us manage these kinds of hidden dangers?
It's a fascinating question about the frontiers of detection and intervention.
Absolutely. So if you have specific concerns, maybe a family history of vascular problems, we hope this deep dive has underscored the value of staying informed and, of course, talking through any potential risks with your own healthcare providers.
And for anyone with a deeper clinical or scientific interest, the Rutherford's textbook chapters we drew from offer a wealth of additional detail.